I don't know what to say, either good morning, good afternoon, or good evening, depending on where you're located. I'm in Bologna, Italy, and it's 9:30 p.m. It's snowing right now. I had a very busy day at work, but I was looking forward to this webinar tonight. So I don't know, it's not very nice to say it, but lymphoma is one of my favorite cancer, and I have been chasing it during the past 10 years. And I have to say, we have done a lot of progress. So I hope you will enjoy this presentation, and please feel free to ask any question at the end of it. So it is hard to imagine a more complex category of disease than lymphoma, and the great diversity in the stages of B and T-cell lymphopoiesis explains the wide range of lymphoma entities, de facto with clinical and therapeutic diversity. In the last decade, advance has been made in classifying, treating, and predicting the biological behavior of canine lymphoma. However, the journey from best diagnosis to best treatment is still in progress. So, lymphoma is not a single disease, rather it represents a wide range of entities having clinical and therapeutic diversity. Back in 2011, Valli and co-authors updated the classification, identifying more than 30 different histotypes. The gold standard to a definitive diagnosis is histopathology, followed by immunohistochemistry. However, histopathology is not routinely performed in dogs with lymphoma. In fact, only 28% of veterinary oncologists all over the world recommended histopathology, according to a recent survey. We now know that histology and immunohistochemistry are essential to obtain a definitive diagnosis. And this is really important to anticipate the biological behavior, ultimately to guide treatment. If you have a look at the published, you will realize that in the last 5 to 7 years, a lot of papers have been published trying to describe specific histotypes, and there are really a lot of differences that have emerged from these studies. With the increasing knowledge about cancer biology, it has become clear that the complexity of lymphoma classifications and the prognostic importance of the architectural assessment in lymphoid neoplasms advocate excisional biopsy, so lymphadenectomy, to confirm and better characterize a primary cytological diagnosis of lymphoma, to accurately determine prognosis and guide therapy. In contrast, incisional biopsy only provides a glimpse of the architecture, thereby limiting the interpretation. I would like to show you a couple of cases just to make it clear. This is the cut surface of a lymph node, of a peripheral lymph node of a dog with lymphoma. This dog had follicular lymphoma, which is an indolent lymphoma. If you only take a biopsy of this lymph node, then you can see that there are neoplastic cells. However, it's impossible for the pathologist to diagnose the exact histotype. In contrast, if the pathologist receives the whole lymph node, then he can see the whole picture, and only in this case he can provide a definitive diagnosis. The same holds true for the diffuse large B-cell lymphoma, which is the most common histotype in dogs. the LBCL, diffuse large B-cell lymphoma, is an aggressive lymphoma of B phenotype. But again, if you only take a biopsy, your pathologist won't be able to tell you what type of lymphoma it is. And we now know that it really has therapeutic implications. The same happens with immunohistochemistry. On the left side of the slide, you have the lymph node that I showed initially. So this is the follicular lymphoma. And if you stain this lymphoma with CD3, which is a marker for T lymphocytes, you can only see that the areas where lymphoma is present do not stain with CD3. CD20 on the right side of this slide stains B lymphocytes, and here you can see that the areas where lymphoma is present stain with CD20. So if you have the whole lymph node, it's easy to tell that this is an indolent follicular lymphoma of B phenotype. Again, if you take a biopsy and you send this to your pathologist, he will be confused at the end of immunohistochemistry because he will only see that there is a double population, a CD20 positive population and a CD20 negative population, but he won't be able to tell you more because he doesn't have the general overlook. If you send a lymph node, then he will see the architecture and he will be able to provide you with a definitive diagnosis. Why am I saying this? Because it has become clear that there are 4 biologically distinct morphological groups having prognostic and therapeutic implications. There is the group of the indolent B-cell lymphomas, including the marginal zone lymphoma, follicular lymphoma, and B small lymphocytic lymphoma. There is the group of the aggressive B-cell lymphoma, including the diffuse large B-cell lymphoma, the LBCL, the Burkitt type lymphoma, and the B lymphoblastic lymphoma. There is the group of the indolent T-cell lymphoma, including T-zone lymphoma and T small lymphocytic lymphoma. And finally, there is the group of the aggressive T-cell lymphoma, including peripheral T-cell lymphoma and T lymphoblastic lymphoma. We now know that all these histotypes, these different histotypes, behave in a different way and need different treatments. Beside histotype, we also need to know the clinical stage, because only if we have those 2 variables, histotype plus clinical stage, we can pick the best treatment and anticipate prognosis. The pre-treatment clinical staging, which is derived from the WHO guidelines, accomplishes several goals. First, it determines the anatomic extent of lymphoma. Second, it allows an accurate prognosis to be given to the owners. Third, it helps directing therapy. And last but not least, it allows to accurately restage dogs at the end of treatment to document the type of response. Historically, 5 disease stages have been described. While the prognostic significance has been validated for the aggressive lymphomas, it remains unclear whether stage 5 disease, which means basically blood or bone marrow infiltration, retains the same relevance for the indolent lymphomas. And this is because indolent lymphomas are typically leukemic at diagnosis, at admission, and this is not necessarily associated with a poor prognosis. Therefore, Today, we start to think that the WHO staging system only applies to the aggressive lymphomas. The staging workup begins with the clinical history and physical examination. We need to assess the location and size of the affected lymph nodes by accurate two-dimensional measurement. And then we use such measurements as baseline against which subsequent measurements can be compared.